Hi, so this is a talk that I gave today, or I'm going to give today in the morning. Sorry, and I thought I'd just put this up on YouTube if anybody wants to reference this later. And it's called "Surprises in Radiology." I first gave this earlier in the year in March at an infectious disease meeting, and I thought, and now I have one at their national conference. So I thought I'll just put this up. So, this is titled Surprises in Radiology, and it is about when we get surprised and what are the rules that we should be following. First surprise, 54-year-old presented with a large left upper lobe mass referred by a radiation oncologist, and it looks like a malignancy, lymphoma, carcinoma. That is what would be our first diagnosis. The requisition mentioned the same thing, and the rule is you do culture what you biopsy. So even though it looks like the pretest probability is malignancy, we sent the material for fungal and it turned out to be Cryptococcus gattai. And then the patient was on antifungal treatment, and you see how the lesion has significantly regressed over time. So the first surprise is when you think it is tumor, but it turns out to be infection. This was a 46-year-old PLH, a person living with HIV and AIDS, who again presented with this large mass here, active on PET, partly encasing the pulmonary vessels, but without narrowing. And so the thoughts were lymphoma, carcinoma, perhaps a large fungal mass. This doesn't behave like a POCI sarcoma. The biopsy turned out to be PCR and culture and histopath positive TB. And the patient on anti TB treatment 6 months later shows significant improvement. And this is true in other parts of the body. And I have shown this earlier in my cardiac MR talks. A 37-year-old with dyspnea, mass in the right atrium on echo. This is always an angiosarcoma or lymphoma unless proven otherwise. But the MR also showed an infectious spondylodiscitis, which I aspirated, and it turned out to be tuberculosis. And then the patient's been followed up. So after about 2 months, the lesion had increased or decreased in size, and then over a period of time has kept decreasing in size. And the last follow up was in, I think, 22, after which the patient hasn't come back. The rule, therefore, is irrespective of your pretest probability and irrespective of who has sent the biopsy, it may come from a medical oncologist, a surgeon, always take material for culture. But the question then is, how much material does one take and for how many organisms? This is a 37-year-old, again referred by a medical oncologist, large mass encasing the SVC. Patient had an SVC syndrome. One earlier biopsy was negative, and pretest probability was lymphoma versus small cell carcinoma. But the histopath diagnosis was likely mucor. I'd taken micro for TB, but not for fungal, as there were cost constraints, and infection was not part of the differential. So, how much material does one take? For how many organisms in a patient where infection is not really a differential, right? That is a challenge, and we face that on a daily basis. The second surprise is this 15-year-old presented with fever. You have a necrotic prevascular space mass. These are the usual differentials anywhere in the world, the terrible fours, and then we add tuberculosis in India. Because of the necrosis, it was called TB, not biopsied, put on anti-TB treatment, no response. 2 months later, the lesion has significantly increased in size. Then I biopsied it, turned out to be lymphoma, couldn't subtype, then did a PET CT, then biopsied the active area, and it turned out to be marginal zone lymphoma. So the second surprise is when you think it is infection, but it turns out to be tumor. And most of the times it's because we fall into this trap of wishful thinking that it is going to be or should be infection and then don't follow the rules. Example, in this case, even in India, a prevascular space mass, even if necrotic, is almost always a tumor unless it is part of a spectrum of multifocal necrotic nodes in the mediastinum and other parts of the body. A purely prevascular space mass is almost always non-TB. This is a 52-year-old, and I've shown it as a whoops lesion at bstneoplasms.com. This was the X-ray osteolytic sclerotic lesion, diffuse cortical thickening. The MR doesn't show marrow edema, so infection gets ruled out. There is extraosseous extension, and this is classic cartilage. So ideally, this should have been called chondrosarcoma, but the radiology report said osteomyelitis. The orthopedic surgeon went in, put a nail, drove all the tumor tissue all around everywhere here. The the biopsy material was not sent for histopath because everybody assumed it was only sent for microbiology. And then the lesions progressed. The patient eventually underwent amputation. So each time we biopsy something or curate or operate, the material has to go for histopath and micro every single time. Unless it's a tumor that you know is a tumor and you're doing it to get material for mutation studies and genomic studies, this needs to be done. Third surprise, 8-year-old girl, distal radius lesion, osteolytic marrow edema, periosteal reaction, periosseous edema, no collection, no cortical break. Did a biopsy, negative. Then the patient gave a history of pain in the other joints, went to a pediatric rheumatologist who asked for a whole body MR, and you can see these multiple metaphyseal lesions, most of them asymptomatic. So it's multifocal disease. This is classic chronic non-bacterial osteitis or CNO. Patient was given pamidronate, and you can see 1 year later, all these lesions have almost significantly regressed. So surprise 3 is when you think it is infection or tumor, but it turns out to be neither. And one of the classic examples is CNO, which encompasses the earlier term of CRMO and SAPHO. It's both pediatric and adult. And usually we get multifocal, sterile, inflammatory bone lesions presenting with bone pain and a waxing waning clinical course. Sometimes can be solitary, as in this 21-year-old who had this horrible clavicular lesion, thought to be Ewing sarcoma, some malignancy, but unchanged over a year, 2 negative biopsies, a whole body MR and CT done. I did the third biopsy, which was negative, and you see these areas of osteolysis, sclerosis, etc. And then there was this one focal lesion in the mid femur, which was of questionable significance. But given all of this, this is characteristic, especially if it's clavicle, of chronic non-bacterial osteitis. So just treated with IV pamidronate, anti-inflammatory drugs, and you can see 18 months later the lesion is almost completely regressed. Pediatric CNO is mainly appendicular. Adult is more central or axial. So above the age of 30 or even as above the age of 20, if we see clavicular, sternal, rib lesions that look bad, but biopsies are negative or are associated with asymptomatic lesions elsewhere, then this would be CNO. It's not an easy diagnosis to make. You must think of the diagnosis in girls between 7 to 14 years of age with multifocal bone involvement or with single site disease, which is tibia, clavicle, mandible, distal radius, typically metaphyseal disease, but there will not be a cortical break or soft tissue. If it's single site disease, a negative biopsy helps us to rule this out. But the best people who make this diagnosis are rheumatologists and pediatric rheumatologists. This is the fourth surprise. 26-year-old had backache and fever and presents with this infectious spondylodiscitis. There's disc involvement, both vertebrae, anterior epidural and soft tissue, bilateral psoas collections, which would be TB unless proven otherwise in India, but you still have to biopsy it. And I did, and Dr. Camila Rodriguez called up saying she can't sign out the report because it's an organism that only occurs in a specific part of the United States. So while history is important, so is geography. And it turns out the patient had studied for 2 years in Arizona. And anybody, what is the common organism that occurs in Arizona? It's Coccidioides immitis. So surprise 4 is when you suspect infection, but the type of infection still surprises you. And this is typically seen with spine infections. And I've learned of organisms I didn't know existed. These are all tongue twisters. Serratia marcescens in this patient with a dorsal infectious spondylodiscitis. 56-year-old with Burkhold area. And, I have that talk on spine infections that I gave about a month ago. And I think I'll put up a link here in the top right corner for you to get there. Post-ops are even more interesting. This was Stenotrophomonas multifilia. It's a tough thing to look at. I mean, to even talk about it. This, while Corynebacterium is often a commensal or can be a contaminant, this was real. Corynebacterium striatum happened because it contaminated the spine after surgery. So it is important to take material for all of these conditions, and then that becomes another challenge as well. How much material do you take and how much is possible? Look at this 69-year-old sputum positive MDR TB. These bubble lucencies are worrisome. You get them with fungal infection, vasculitis, etc. On treatment, not improving clinically. I did a CT guided biopsy. It turned out to have Enterococcus fecalis along with the TB. Then the histopath showed mucor, and then finally cultured mucor. So you have mucor, you have E. fecalis, and you have TB in the same patient. And you would only know that if you've sent for all of these things. The fifth surprise is for radiologists when you get the biopsy requisition note from the referring physician. So the request form for sample. So earlier when we started doing biopsies 30 years ago, it was FNAC versus biopsy. People were happy if you just got some material for histopath and TB culture. There was no PCR at that time. And that was pretty much it. Sometimes you did aerobic culture and very rarely fungal. And even today, if a chest physician or MD physician sends a requisition, it's really histopath, TB PCR, TB culture, fungal, and only if it's acute, then the patient may send for aerobic. But if the patient comes from a spine surgeon, even if you're suspecting tumor, right, and your whole idea is to just, pretest probability of tumor is 99%, they still want all of this, including KOH mount, including brucellosis, and then sometimes they add a little extra here depending. So nowadays they write LPA, and some of them have started writing biofire. So there is no end to what they want. ID physician, when it comes from you, them, then it's all of this. And that's again a challenge, because how much material do you take for what? And it's not easy. And a medical oncologist has another set, because they want histopath, then they want immunohistochemistry, and then they want this whole bunch of genetic studies to be done. Our work is getting tougher and tougher every day. So to summarize, surprises in radiology: when you think it is tumor, but it turns out to be infection. When you think it is infection, but turns out to be tumor. When it turns out to be neither, as in chronic non-bacterial osteitis. When you suspect infection, but the type of infection still surprises you, and which is why you need to take a lot of material for everything. And for radiologists, when the list of tests and the biopsy requisition is the main surprise. And I thought this was apt for this meeting. A fever is not a sign of ceftriaxone deficiency. I hope you've enjoyed this lecture. Thank you so much for listening to me.